We're so locked into the way the money moves that we don't ask ourselves some of the most basic questions about the principal actors in our system. The one that's relevant here: what is a hospital? We actually don't step back to ask ourselves that question. I'll tell you one thing: over the history of US healthcare, here's the one thing a hospital has never been: a competitive business that manages the costs of advanced clinical care and delivers it at a fair price.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. The purpose of this podcast is to tell the stories of Alaskans of interest and importance. But today, our guest is not an Alaskan. It is Dr. Bill Sage, who is the Assistant Vice President of the Texas A&M Health Science Center. He is also a professor of medicine at Texas A&M University School of Medicine, and he is a professor of law at Texas A&M University School of Law. He has published literally hundreds of papers over the decades on health law and policy, and he has edited 4 books, including the Oxford Handbook of U.S. Health Law. He has previously been a professor of law and medicine at UT Austin, Columbia Law School, Yale, Harvard, and NYU. Although we will be talking about American healthcare policy, our conversation is relevant since the Alaska healthcare system is a microcosm of our national healthcare system. This interview is part of a series on Alaska healthcare policy. Please check out the recent interviews with Dr. Ann Zink, Lawrence Weiss, and Kendra Sticka for a more Alaska-centric view. Dr. Bill Sage, welcome to the podcast.
Thank you, Andrew.
Tell us a little bit about your childhood. Where did you grow up?
I didn't expect to be on a virtual couch at the beginning. Yes, I grew up in New York City in the middle of Manhattan.
Did your parents know that they were raising someone who was going to be a lawyer and a doctor?
They had no idea, though. I was an only child of older parents, and I guess that was my way of paying them back for all the wonderful things they did, was to take on 2 careers where I'd have the student debt of both and the earning power of neither.
How did you decide to do that?
I had been conditioned to go to medical school. My father was a physician of a much earlier era. He graduated medical school in 1937, and he had 2 different specialties. He started as a radiologist. He served in World War II and set up some radiology departments and got too much radiation exposure.
Right.
Very sick at the end of World War II. And when he came back and was discharged, he retrained as a surgeon. He ended up doing cancer surgery. My mom was in fashion advertising. My dad wanted me to be a scientist and liked the idea of me going to medical school to be a scientist. So did my mother, but I also grew up in a school system that was very good with humanities, social science, and writing. So I went off to medical school thinking I was just going to medical school, and then the rest just happened.
Where are we recording? Where are you?
Right now, I am in New York City, and you may hear some sirens in the background because it's United Nations Week. There are barricades, NYPD officers, and motorcades everywhere.
I want to dive into healthcare policy. I'd like to start by having you read the first couple of paragraphs of a paper that you published in 2021 in the Ohio State Law Journal on what the pandemic taught us.
This was a comment on some other law professor's article, and that law professor was talking about the public responsibilities of healthcare organizations, making analogies to what we now think about as the public responsibilities of just large corporations. And my take on this is, of course, there are public responsibilities for healthcare organizations, and there always had been. But this led me into talking about the pandemic experience, and what the article is called is What the Pandemic Taught Us, which is that the healthcare system we have is not the system we hoped we had. Do you really want me to read these paragraphs?
I do. I love these paragraphs so much.
All right. Thank you. Very nice to have a fan. The United States spends nearly twice as much per capita on medical care as any other country. The United States has the world's most advanced biomedical technologies, sophisticated hospitals, and skilled health professionals. The United States has a national public health body, the Centers for Disease Control and Prevention, that is generally considered the world's leader in infectious disease detection and response. Nonetheless, the United States suffered among the world's worst COVID-19 disease burdens and outcomes. inflicting largely avoidable harm on patients, health professionals, and the broader community. Why this happened is clearly important, but that it happened is itself significant. Criticisms of the U.S. healthcare system abound, but often have a Lake Wobegon character, coming from another set of famous radio and television broadcasts. The healthcare system itself may be bad, but my personal doctor is good, is what many people think. Kind of like Lake Wobegon, where everybody was above average. A silver lining of the pandemic experience is the possibility that Americans will finally recognize that whether or not one's own doctor is in fact good, American healthcare is unreliable, wasteful, and unjust.
Many of my Republican colleagues do not believe that our country failed during COVID. I'm surrounded by this narrative that there was an overreaction and that COVID wasn't a problem. The revisionist history of what just happened in the past few years. If you can talk about how COVID stress tested our healthcare system, how it showed that we failed compared to other countries, I really do believe that there's a large percentage of the population that's not aware that we did not perform as well as a healthcare system during COVID as other countries.
So that's a great question. To rephrase a bit, you'd like me to clarify what I mean when I say the US did not perform as well as other countries in COVID. As you also mentioned, you said stress test the system. And I think that's exactly what happened is we stress tested our healthcare system and we found it wanting. And I'm not going to make much in terms of a statement about the science or public health interventions in COVID. I think there's two things that we can learn from Matt, and I hope we can all agree on it, regardless of one's perspective. One is that learning is important. Nobody starts with a new situation knowing what to do. You have to learn, and you're going to make mistakes along the way. Another way to say this, though it could be quoted out of context, but I'll take the chance. Every scientific conclusion is wrong. It's just less wrong than the one we had before. And you have to understand that science is always going to be imperfect and needs to be correcting, much the way that policy and other conversations need to be correcting. People need to learn from experience and admit when they're wrong and have a little humility, which is something I hope we'll come back to, because I think humility for all of us is incredibly important. Yes, we all believe that we know a lot. We believe we've learned a lot in our careers. We believe we have a lot to contribute, but we have to be able to listen. We have to be able to stop. And when someone says, wait a minute, what you're doing doesn't seem quite right, we can't just say, oh, you're wrong, we're right, and go forward. And so I think one lesson of the pandemic is everyone has to understand that we're always going to be wrong. We're hopefully going to be less wrong than we were a month ago, a year ago, 5 years ago. And so that it's a false search for certainty. The other thing we should have learned both about our healthcare system and about the pandemic is we are in this together. The big failing for me in Obamacare, which I support and was so enthusiastic about, I got my kids so excited when it was up for a final vote in the House of Representatives, that as the votes climbed towards passage, my son, who was 10 years old, jumped out of bed, ran into the bathroom, and got sick because he was so nervous. So I'm very much in favor of a lot of things in the ACA, but I think the big gap in the ACA is it had really no sense of in this togetherness. It had no sense of solidarity. It almost ran away from the notion that it was a national program. It never got closer, as I've written on a few occasions, to solidarity than consumerism. It brings consumers into the American public. And what we have to remember from the pandemic is we are in this together. And in our healthcare system, we are also in this together.
I did read your article on how to market the ACA, which I wasn't planning on talking about. But since you brought it up, I think that article is really interesting because it talked about how in order to pass the ACA, they had to de-emphasize what a big change it could potentially be. They had to make it seem like it was very moderate and making very small changes. And an unexpected side effect of that is that after it passed, there really should have been a marketing strategy. I think you called it like AmeriCare, and creating a sense of ownership among the American public of this new healthcare system, and people feeling involved and excited in it. And that didn't happen.
I think now there's this consensus that as people become used to the things that it has provided, then people have more of a stake in keeping it than they did for many years. And there were many reasons for the delay, which I could unpack for you. A lot of them come down to the artificial way in Congress that we have fiscal legislation, budgetary legislation, that functionally means that any significant new law has to pass Congress twice. It has to pass once on its merits, and it has to pass separately on its fiscal impact as calculated, which is not the same as its fiscal impact if it really is implemented. And so much of the ACA was designed to pass those budgetary mileposts during debate that there were a lot of sacrifices made in terms of what would have been its political reception. And a lot of decisions were made that, in my view, set it up for the litigation it experienced.
Because as a new legislator in Alaska, I can say that whether or not your bill will be referred to the finance committee based on how much it costs causes you to make some, in my opinion, really dumb decisions. We will opt for less good policy for a very minor change in fiscal impact in order to say that we have no fiscal impact. Please pass this bill.
And that's perfectly understandable. And the ACA, because healthcare is just a little less than a fifth of the US economy, is going to have so much budgetary impact as calculated that a bill will stand or fall on the way that the Congressional Budget Office scores it. There are lots of examples, but I don't want to get too inside baseball. The one that is, I think, possibly of interest to your listeners is the decision to cap the federal contribution at 90, not 100% of the Medicaid cost in the Medicaid expansion. And in fact, the thresholds for the Medicaid expansion to be triggered. So if you really get in the weeds of this legislation, you may see competing numbers that Medicaid will cover in expansion states up to 133% of federal poverty or 138%. That was a budgetary calculation. Much of the expansion of Medicaid was a budgetary calculation for the following reason, which some of your listeners may appreciate. The calculation of how much it costs to insure someone is significantly greater if they're privately insured than if they're covered by Medicaid. And so there was a budgetary incentive to put at the margin people who would get new insurance into Medicaid rather than into subsidized private coverage.
Hey, bouncing back, what kind of doctor are you?
I am a licensed physician in Texas. I've always, as a matter of professional pride, had an active medical license somewhere. I don't have a clinical practice. I did, after my medical and law schools, which I did as a 6-year joint degree, I did a year of general internship in California. I began an anesthesia residency in Baltimore. After a year of that, I went to practice law for a while. I was planning to finish the residency, but I ended up going into sort of the policy side and then into law teaching and never finished the residency. So I am a not fully qualified anesthesiologist.
I had some questions planned today about the amount of money that doctors make, and certainly anesthesiologists would be right up at the top. In fact, I would make a stereotype that the reason why anesthesiologists become anesthesiologists is to make money, because in my very limited understanding is that most people don't think, oh, what I want to do is put people to sleep. Then I won't really have a relationship with my patients. They'll be unconscious. So I don't know if you could speak to that at all, like why you were going to be an anesthesiologist.
I think It's relevant to this conversation. So by the time I was in medical school, I enjoyed every piece of clinical medicine I did. But when it came time to choose a residency field, I hesitated and I thought I'd really love to have a law degree also. And so I added in my law degree starting in what would have been my fourth year of medical school. And as I went through that process, I realized that I wanted personally to have a career that had some individual contact. And I thought that would be clinical. It turns out it's much more classroom. I love teaching. It's a passion. There's nothing more fun than being in the classroom, but also have some aggregate impact, some kind of collective impact. And then I was thinking, as I was finishing my degree, I had no idea I'd ever become a law professor. That's sometimes a long-term plan for people. It was not for me. I thought I'd become an academic physician, but I was trying to choose a field where your patients were not relying on you 24/7. And so you wanted a field where you could have deep clinical engagement, but then you could walk away and do other things without letting any patients down. And so anesthesia was one of those fields. And that's why I picked anesthesia.
During the 80s and 90s, Alaska paid its public school teachers more than any other state. And we had no problem recruiting public school teachers in Alaska during that period. We also had an amazing retirement system for teachers. We now have a big problem. We don't have enough public school teachers. And an argument that you'll hear from some is that teachers shouldn't go into that field for money. They should go into it because they have a love for teaching and for children. And I think, I could be wrong, but I think maybe 100 years ago, people would have made the same argument about doctors going into medicine. The doctors don't go into medicine for money. The doctors go into medicine because they want to help people and prevent unnecessary suffering and cure disease. And I think that, as I made the joke about that people become anesthesiologists for the money, that there are certain specialties where I think that is the stereotype. When we talk about the budget for healthcare in Alaska, more than half of the spending is on salaries. And you've written a lot about how healthcare has not followed the same trajectory as other industries, where they automate, where they find lower paid wage workers to do similar jobs in order to cut costs, and that we haven't seen that as much. And I don't know where my question is, but I'm...
That is no problem. So let me try to unpack that a few directions. And I'm going to start with an anecdote. I had two moments in my young professional career where I decided I needed to do something different. And I had the luxury of this. And I am so grateful to my parents. I am so grateful that I could do these things when they presented themselves. But one was to get off the conveyor belt of medical training in law school. The other was I'd never been involved in politics. I'd grown up in New York City, and it was largely Democrat. But it was very balanced. We had a moderate Republican congressman, moderate Republican senator during my childhood. But at any rate, I had gotten really interested in health policy. And then Bill Clinton got elected. And I was a very young junior lawyer, and I decided I would find a way to work in the Clinton White House on that first few months of chaotic healthcare reform that some people remember as Hillary Care. And that was my fire hose experience in health policy. And that is what led me into a policy and academic career. I met Bill Clinton only twice during that time. When I did meet President Clinton, a few of us were given small introductions by the person in charge. And I was somewhat oddly introduced to the president as someone trained in anesthesia and in securities law. And Clinton looks at me and says, for the whole room to hear in a loud voice, "Oh, that's great. You put them to sleep and take their money." The first time I told this was about a week later. It was a gathering across the street from the White House of the Washington Business Group on Health Executive Committee. These were people who managed healthcare expenses for Fortune 500 companies. And I gave the punchline, which was true: put them to sleep, take their money, and people laugh. And then there's a voice in the back says, yes, and that's just the anesthesia part.
I didn't laugh when you told it the
so-
first time. And I got to tell you why. You know why I didn't laugh? Because I didn't laugh because it was true.
Now let me get more serious.
Yes.
Let me get more serious with you and unpack your question. So the first thing that is really, really important to say is that the people in healthcare are fabulous. Our systems are not. I do a lot of work on medical error and patient safety, and our systems have so much to be desired. And the only reason we don't harm so many more people is that our nurses, our physicians, our support folks in advanced healthcare settings are terrific. They're skilled, they're hardworking, and they care. And whatever we talk about in healthcare, you have to start there. The people matter. And in fact, I keep learning myself. And one thing I've learned in recent months is to focus on the people and not to focus on the money, because I think we keep leading ourselves astray focusing on the money. That said, let me agree with you on teachers, but bring us right back to healthcare. And here we're going to probably end up talking more about nurses. So if I have to describe myself politically, and I do, I say, look, I'm a liberal Democrat who loves markets. I love and understand how markets work, and I value them every time there can be a functional market. I value it. Other than that, I have instincts that have to do with caring, supporting, educating, and serving. And that's me. I do, as you do, work in a state that is, by and large, very conservative. And I love talking to people who hold different assumptions than I do about what a good policy will be. And here's what I often say. I say, look, I'm going to offer you a really radical thought about healthcare reform. And I get a very skeptical look. I say, here's my radical thought. When a healthcare professional does something that measurably benefits a patient, that health professional should be fairly paid for doing it. And the people I'm talking to are expecting some socialist proposal to come out of my mouth. And I say that, and they say that's not radical. And I say, in American healthcare, yes, it is.
Can you break that down?
It's a very radical statement, because we don't pay anyone for measurably benefiting patients. Many of the things that people do, as I said, they're great people. They're trained, they're dedicated, and they are compassionate. Many things they do benefit patients, but we don't pay them for that.
Mm-hmm. Right.
We pay them for particular codable process steps that have grown up over the decades in the post-Medicare world, and for the various technological inputs to those process steps. We don't actually pay them in a considered way for doing stuff that helps. And when we talk about physicians, we pay physicians presumptively for everything they do. When we talk about nurses, and remember, there's more than twice as many nurses in the United States as there are physicians, we pay nurses presumptively for nothing they do. So if you're a hospital, and remember, hospitals today may employ most of their physicians and most of their nurses, and you'd think those two groups would be treated as professional colleagues and participate in an organization similarly, and they don't. Physicians are paid separately, and hospitals treat everything a physician does as revenue. Nurses are not even identified individually when they do things. And everything nurses do is subsumed as undifferentiated but very high labor cost, and is folded into overhead associated with a hospital bed. So you asked a little about the pandemic. So I sent you a piece that I co-wrote with a nurse informaticist who's on the University of Utah nursing faculty, who previously was one of the people operationally in charge from a nursing side of major New York City hospitals during the pandemic. She tells a story which sounds apocryphal, but isn't, which is in the worst moments of the early pandemic, as all sorts of people couldn't breathe and needed intensive care, all the hospitals were swamped. And I was in New York also. I was teaching as a visiting professor at a different university that year. And we all saw it on television. We saw people lying in the hallways in hospitals, and everybody on the news reported that there was a critical shortage of hospital beds. You know what happened? Lots of people, really well-intentioned people, called up hospitals and said, I heard you have a shortage of beds. I have a bed in the attic.
Oh my
We
God.
send it to you.
So they didn't understand that it was about staffing.
Exactly. They thought that this was a piece of furniture, not a fully staffed bed that could serve a patient with an acute clinical need. Okay, I spent a lot of my policy career trying to notice things that other people just don't notice. So a lot of what I contribute is pointing out things that are actually obvious in hindsight. So here's something people don't notice. Nurses aren't furniture. So you ask about the people and about getting fairly paid. And by the way, here we're not talking about nurse practitioners. I very supportive of nurse practitioners, but nurse practitioners are practicing medicine.
Right.
Other nurses are practicing nursing and they're really good at it. And a lot of things they do are absolutely critical to delivering high quality care in all sorts of settings, hospital settings, community settings, public health settings. We treat those nurses as furniture and hospitals treat them as cost. And some of this is just astonishing to me. I read a very well put together list about a month and a half ago of nurse earnings by state, all adjusted for state cost of living. It was very informative. And then I realized something. Every single state, what is listed is an hourly wage.
Mm.
Try to think of a profession where the average earnings are ballpark $100,000 a year, where when we write about it, we print an hourly wage. Doesn't happen.
Most of them would do the yearly salary.
Right. But because hospitals budget nurses as costs folded into overhead, which is all a matter of estimating how many beds will be in service in a given shift, calculating from hourlies and overtime how much it will cost to staff that bed. And at the end of the day, nurses actually make a fair amount of money, but here's what nurses don't know. They don't know how much money they're going to make. You try raising a family, try taking out a mortgage, try saving for your kids' college where you might know you're hourly, but you don't know how many hours you're going to be asked to work. It's not very practical, and certainly not the way we should be treating nurses.
In your article from 2016, Mining P's and Q's, the political and policy questions framing healthcare spending, you talked about a real problem with the fee-for-service model that generates physicians' income, that procedures are overused, physicians neglect simple preventative measures in favor of complex therapeutic ones, health professionals and health facilities bill separately, and that avoiding complications reduces profit rather than raising it, and that defensive medicine enhances revenue without adding value. That's your quotes from that, where I feel like that's really pointing out that the way we're paying our physicians encourages bad behavior. And I almost think when we talk about a nurse making an hourly wage, a physician making an hourly wage would remove some of these perverse incentives.
Well, a health system that doesn't expect that every service a physician does will generate revenue will be a better health system. I've always wondered about this myself. Almost every major health system in the country depends on physicians delivering services that can be coded using CPT codes. And by the way, if you don't know this, the American Medical Association owns the copyright in CPT codes and makes a very large, if not publicly disclosed amount of money licensing that every year. Those codes are what get negotiated by the Relative Value Update Committee, generate the amounts that are paid for those services by the government, and then because those services are also used with similar codes by private insurers, generates codable claims for private insurers. Yes, this is an enormous problem, and it's an enormous problem even at a human level. Am I really worried that doctors are making too much money? No, I'm not particularly. Am I worried that nurses are not being fairly paid for things that nurses do that really help? Yeah, I am worried about that. And I'm really worried about that because as we turn towards non-medical drivers of health, and particularly in the pandemic, when we look towards community-based nursing as a way to do really good prevention and treatment and reduce discrimination and boost outcomes, nurses weren't going to be paid for much, if any, of that. And as you say, should people be in it for the money? No, I actually don't think really anybody in healthcare is in it just for the money. I think there's a lot of motivations, and many of them are really admirable. There is something to professionalism that I think is real and that we should care about. But our system on the whole doesn't reward it. And the nurses who are asked to do things in the community because they're nurses and they should care, that's not fair. And when we say, oh, when you're not doing your paid work on the hospital unit, we'd also like you to maintain a food pantry, but we're not going to pay you for that, but we should do that because you're a nurse and you care. They are a nurse. They do care. They're great, but we should be paying them to do that, and our system should pay to do that. And that's a big problem. The codes that generate claims is a massive problem. It's also a massive problem for physicians' careers because you find yourself on a treadmill, and the treadmill is a treadmill to generate RVUs, relative value units. In other words, the things that get coded and, quote, reimbursed by all the insurance companies. And that really limits physicians' career opportunities and makes it less likely that a physician who is aging and shouldn't be doing as much direct clinical care doesn't necessarily have other fulfilling options, doesn't necessarily have a work environment that values what that very experienced physician can contribute. We're going a little all over the place, but I think what I'm trying to emphasize for you is that the more you think about the people, the easier it is to see the problems with the systems.
I do want to make sure that we have time to talk about two specific issues. One is when talking about the fee for service model, I read so many of your papers yesterday. The danger of doing too much cramming is that it all blends together. But you did write about Kaiser Permanente in California as a HMO, as a model of something different than a fee-for-service model. And what we have in Alaska just past this session is we allow for direct primary care in which folks pay like a subscription monthly fee, and then they have a primary care doctor that does not bill insurance. And to me, it's like a very small scale version of Kaiser Permanente. Obviously, there's no specialties there. There's a lot of fear by certain legislators that this was going to just be rich person's care, and that obviously somebody who's making minimum wage can't afford to pay a monthly fee for primary care when all they can get there is primary care. But I just didn't know if you were familiar with the direct primary care model and if you had thoughts on it.
So I'm not familiar with Alaska's version. In general, anything that can disrupt the pattern of reimbursable codable claims is likely to be useful, but it just has to be real. The things that the fees pay for have to be valuable, useful, understandable. You have to understand what you're getting. If there's big gaps in what you might expect to get, say, not that anyone has the need for a particular imaging test, people have the need for an accurate diagnosis and plan of treatment, and imaging might be part of that. But if there's some big ticket items that aren't in this fee, then you do have to worry about how people are going to be able to afford that. The other thing is, I don't think you can liberalize the payment models if you also have highly constrained practice models. It's always struck me as paradoxical that states, including Texas, that espouse a belief in the free market also have pretty severe restrictions on who can practice medicine. And to me,
Right.
the two don't go together.
Speaking of those restrictions, can you talk about North Carolina State Board of Dental Examiners versus the FTC from 2015?
So this, I have a social acquaintance with a member of the U.S. Supreme Court, and when I make a point of not saying anything about cases before the court, but when this particular case was accepted for review by the U.S. Supreme Court, I ran into this justice and I said, and I just wanted to tell you that for those of us in the health law community, it's a really important case. And the justice looks at me and said, all our cases are really important cases. And what I was trying to say was, this wasn't about Obamacare. This wasn't something that was going to make the news. And the fact that it mattered in healthcare was significant. So what I will say about this case is what we now know it has led to. And what it is, the thing it has led to is a new set of political compromises. It is not just for dentistry, which was the subject matter of the case, or for medicine, but also for law and some other professions, state licensing boards that took really hard lines about other people doing what they thought their members were exclusively entitled to do, got a little chastened by this case. Because what this case said was that the North Carolina Board of Dental Examiners, the state dental board, part of the state, but controlled, as most professional licensing boards are, by members of, in this case, the North Carolina dental profession, could be sued on antitrust law grounds, on federal antitrust law grounds. And this was just a little wake-up call. And it didn't suddenly turn dental or medical services into a productive free market. But what it did was it allowed the political compromises to be revisited. The political settlements is a better way to put it. So suddenly the legislature would agree to hold hearings. The board would participate, the professions would participate, other professions or other challengers to the professional monopoly would participate, and what would come out would be a somewhat different set of rules that would be somewhat more open to broader competition. So this happened in Texas after North Carolina Dental with telehealth. So
like where there were restrictions on telehealth that were basically a protective mechanism. They didn't want to compete with telehealth physicians.
This was Texas physicians didn't want to compete with physicians that were organized by a company and would serve the same patients on a telehealth basis. This is pre-pandemic. And I want to make one important point that has to do with the pandemic. In other words, bring us back to the beginning of this conversation after I make this one. The Texas Medical Board challenged this company called Teladoc and was making it so that Teladoc would not permissibly be able to do what it wanted to do in Texas. And then the Supreme Court decided the North Carolina dental case. And then the telehealth company changed its strategy and filed claims alleging violations of antitrust law. And this changed the landscape because the Texas Medical Board lost in the district court and would have lost even in the Fifth Circuit, withdrew their appeal, and instead the legislature took up telehealth in the next session and changed the rules so that they're somewhat less restrictive. And so I think the lesson is not that we're going to go from a regulated system to a free market system. It's that when you remind people where there are restrictions on markets that serve their useful purpose, this case is one of the things that helps bring them to the political negotiating table with the state legislature to settle on something that would be somewhat more open, but still be sufficiently protective of the public. Now, let me say something really important about the pandemic. So in terms of professional licensing and the excessive occupational licensing that happens in American life, and the ways that it curtails not just access to the services, but opportunities for the people who want to provide those services. Again, if you think about the people, it's not just the people who would receive healthcare or dental care or legal services. It's the people who could do a really good job providing them, but they can't afford the education. They need to move states. They served in the military, something else that gets in, and the occupational license that gets in the way. Over the past 60 years, every conceivable political orientation has concluded the same thing, which is that our licensing laws are too strict. Milton Friedman, from the conservative libertarian perspective, wrote about this in 1962. The Obama administration released a report in 2015 that says almost exactly what Milton Friedman had said. The Trump administration released a report that echoed the Obama administration. And nothing changed. Nothing changed until the pandemic. And Andrew, in the pandemic, more changed in 6 months out of necessity than the best reasoning, data, and advocacy had changed for 50 years before that, which tells you what a strong lock the licensed professions, not just healthcare, licensed professions in America have on important aspects of American life. And now our task is to prevent the backsliding.
This comes up in Alaska in terms of compacting. The nurse licensure compact, for one, has been very much debated. And it's interesting because I have many friends that are nurses. Every nurse that I know personally supports a nurse licensure compact. However, the nursing board opposes it, and the nursing union opposes it. And it's an unusual position because as somebody who wants to reduce the cost of healthcare in Alaska, as somebody who wants to improve outcomes of healthcare in Alaska, and who works in the healthcare industry, every fiber of my being says I should support this compact. But as a Democrat supported by unions, people are coming in and saying, vote no on this. And that is a political reality in Alaska.
And most of the time, I support unions. And again, that is very concerning to me that unions have faded as much as they have in American economic life. And I say this even as someone who really values markets, but I think they play a very important role. In terms of the compacts, yes, it's pretty easy to support them. And I don't think most of the counter arguments hold much water. The question, though, is how effective are they going to be at doing the big picture goals you want them to achieve? And just one seed to plant in your mind is that each of these compacts is limited to one profession. Mm-hmm. There has been an effort over the last 15, 20 years to have at least collaboration involving medicine, nursing, and pharmacy. There is or has been something called the Tri-Regulator Commission. I don't think it's gotten very far because interprofessional collaboration and, frankly, the generosity it requires, particularly among physicians, because they are the apex predator, if you will, in the health professions. The generosity it requires hasn't been forthcoming. But if you want to expand a compact, it shouldn't just be an interstate compact, it should be an interprofession compact.
Yeah, that's interesting. I do want to talk about certificate of need laws because that's another big hot button issue in Alaska. We do have certificate of need laws. The way I would explain it briefly to listeners is that in order to open up a new imaging center, in order to open up a new outpatient surgery center, the folks who want to do that have to prove that there is enough business for them to be able to do that. And there's a lot of pushback. The major hospital system in Alaska routinely says that if we opened some of these outpatient surgical facilities, that we would put them out of business. And then we would have no major hospital system in Alaska.
So I think that tells you something about the way in which healthcare organizations, and again, I'm not naming villains. I don't really believe in villains. And the people in all of these positions are generally great people trying to do a really good job. But think about this. This is telling you that if you're a hospital, what you manage are your revenues. And what your revenues depend on is your mix of payers. how many of your patients are privately insured and therefore more lucrative than federally insured through Medicare, who are in turn more lucrative than government insured through Medicaid, who are in turn more lucrative than people who don't have any coverage. That payer mix determines revenue. And what the hospital's telling you is that they think a competitor who can selectively drain off their lucrative private pay patients will cost them too much revenue. They're also telling you they can't really manage their cost structure, which they can't. Hospitals don't manage their costs very well. And when they say they really don't know how to do it, I understand them. So let me round this out for you. Remember when we started talking, we talked a little about the lack of solidarity, about the in this togetherness piece, the collective piece of all of this, whether it's a public health pandemic or a functioning healthcare system. What we've done in America is we have allowed ourselves to define our healthcare system as the extrapolation to the population level of individual doctor-patient encounters. That's not a healthcare system. We want to support individual doctor-patient encounters. That's fabulous, but that's not a system. And that's, I think, the core mistake that we've made. But think now about what you've just said on certificate of need and the hospitals. We're so locked into the way the money moves that we don't ask ourselves some of the most basic questions about the principal actors in our system. And I call these the what is questions because I teach them. So the one that's relevant here, what is a hospital? We actually don't step back to ask ourselves that question. I'll tell you one thing over the history of US healthcare. Here's the one thing a hospital has never been: a competitive business that manages the costs of advanced clinical care and delivers it at a fair price. You would think in the ostensibly private market-based US healthcare system that we all think we have, you would think that's what a hospital would be. A hospital has never been that. So here's the question: what is a hospital? Do you want it to be that, perhaps? Is it a community institution with a responsibility for the place where it exists? Is it a center of education and research? Is it, as it's often been in American communities, a free workshop for physicians, wherever they might be? But at any rate, these are the basic questions we never ask.
I want to comment on that. And I think I'll quote, is it Kissick, the man who wrote the book in the early 90s? And you, in several of your papers, you mentioned that he talked about that there will never be enough medical resources to satisfy the medical desire. In other words, the demand will always be higher than the supply. And in this case, talking about hospitals, a hospital views patients differently. If somebody has amazing Cadillac insurance, the longer that person stays in the hospital, the better, in a way. And if somebody has no insurance or is destitute, the less time they spend in the hospital, the better. And so there's a different caliber of patients. If they're collecting $10,000 a day from this patient and it's reliable, there's no pressure to get that patient out the door. In the same way there is with a homeless person, it's a drain on the resources. And I don't know if if that makes sense of the way I'm trying to draw it back to the 90s and his comment that our demand will always exceed our supply.
I never knew Dr. Bill Kissick, but he had a role in so many important things in that era of US health policy, from Medicare to the dangers of smoking. The reason I make that comment is what he described was the way we always used to think about our healthcare system, which was that it was all beautifully balanced given how much money we were willing to spend, so that the money we spent was well spent, the quality was high, the access was whatever the money would support, and everything we wanted to change would either require more money or less quality. And I don't think that was an accurate description at the time, and I don't think it's an accurate description today. It's not that you can just point to one thing, one piece of a hospital's incentive as you describe. It's that overall, this system never was anywhere close to optimal, no matter what the American medical profession said about its decisions for patients, which, by the way, weren't necessarily self-assured. The people are good. They just weren't a system. We can do a whole lot better, but in order to do a whole lot better, we actually do need to ask those very basic questions. And for the sound bites that round out a conversation like this, we have to ask them together. If we only ask them as individuals, we're never going to get a better answer than we have today.
Hey, what I would like for you to close off our time, if you can read from the conclusion of your article about what we learned from COVID, and I'll have you read it, and then I'll explain why it's so important to me as a policymaker.
This was the piece that sort of taught us about injustice in our system. People who do healthcare policy work and who are public health scientists have written a lot and calculated a lot and studied a lot of the science of disparity, the science of poor access, but the reality is not that sterile. The reality is we have a system that many of us, all of us in some sense, brought into place over the decades, over the centuries, and we have to recognize the conditions that those choices have created for our health. So what you're asking me to read is focused on racism, but this is a piece that really tells us about the injustice in the healthcare system revealed by the pandemic. As that, among other things, the pandemic exposed the structural racism that had long been embedded in supposedly objective, science-driven prioritization of patients according to potential clinical benefit. This means when we have had to ration care, we've generally said, okay, if you can do better than another patient with this treatment, we should provide it to you. The problem here is that the people who couldn't do better weren't not doing better because it was their fault or something scientific about their condition. It was that the conditions under which they've lived and their families have lived for generations made it less likely that they would have potential clinical benefit, and they shouldn't be further discriminated against for that reason. So what I said was chronic conditions and disabilities often reflect social failures, not personal choices. Communities with high rates of COVID-induced respiratory failure as the result of multi-generational discrimination, therefore, should not be denied life-saving service under crisis standards of care or other systems of prognosis-based rationing. And in fact, these were revisited during the pandemic. The pandemic experience has also reminded policymakers that the laws that matter most to health are not usually those one thinks of as, quote, health law, but rather the laws that help provide economic security, education, jobs, and housing, that improve policing and criminal justice, and that protect basic civil rights from racism and disenfranchisement.
It's so important, I think, for policymakers to hear that. I think when I told folks that I wanted to work on health law, I really was thinking about a series of laws that were different than the types of bills that I've been considering in the last couple of years. From what you've written here, I realized that my housing bills, incentivizing more housing that people can afford, is helping their health.
Absolutely.
You're not the first interview I've done on like this series of Alaska healthcare, and I've interviewed the chief medical officer for the state from 2019 till 2024. And basically, she said, you're going to have to bite off little chunks here and there. There's no way to reimagine the system, tear it down and start over. We're going to just have to make modest, small improvements here and there as best we can. And I don't know if you agree or if you think that we do need to make revolutionary change in the way we do it, if we need to somehow tear down the system and start over.
I don't think we can tear down the system and start over. And I think the fallacy of the Kissick quote is also an invitation to make a real difference with small changes. If we know that the system can get better along all dimensions, rather than every single decision being a trade-off, we should make those changes. But those changes mean we have to notice things that probably are staring us in the face, but we just didn't notice before. Like maybe it never occurred to you to wonder why a skilled paid nurse is still quoted as an hourly wage worker. So I'll leave you with this. Here's a constructive thing that I would be delighted to talk to people in Alaska or anywhere about. As you've gone into health policy and you talk about all the different stakeholders and learn about the stakeholders, I'm sure one of the stakeholders you hear about is employers. But employers in health policy means non-healthcare businesses that sponsor health insurance as a fringe benefit for their workers. What about those incredibly important healthcare organizations that employ all the nurses, these days employ the majority of the physicians? How come when we say employer, we never once mean them? And if we thought seriously about the responsibilities of being an ethical, generous healthcare employer and the forms of accountability to which those ethical, generous healthcare employers should be held, I think it would make a big difference in our system. And that's a new opportunity because physicians were not employees until pretty recently.
I am so grateful for you being on the show today. I'd say if I took away anything, I think something for me to keep coming back to is that there are no villains. It's very easy to view certain folks within the healthcare system as villains, whether it be like the insurance companies who are denying payment for certain care, or whether it be me villainizing anesthesiologists for only doing their job to make money. And I think like reminding myself to go back to that there aren't any villains, I think is important.
It's about the people, which sounds a little trite, but I've come to a fairly recent realization that we spend so much money on healthcare in America that instead of that enabling us to do new things and better things, it paralyzes us. And it doesn't mean we have to give the money back, but we have to stop letting it run our lives and think about what we want in different ways. So you can think about it as the people, or you can find something else you want to think about. But we have so much money in the system that it prevents us from making things better rather than helping us.
Dr. Bill Sage, thank you so much for being on the show today.
My pleasure.
I am dropping links to many of the papers referenced in today's episode in our show notes. Thank you, listeners. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@akleg.gov or call my office at 907-269-0123.